Hello and welcome. I've had a bit of a break from the old Breaking Barriers interviews, but the summer is over. We're back with a bang, and I'm so excited to have Dr. Susanna Unsworth here to talk with us today. I'll give us a bit of introduction, what we're about. So Breaking Barriers is all about having conversations that are with leaders or support leaders, women in the workplace, to break through the challenges that hold us back. And so, of course, a lot of these are systemic and societal, and none more so than dealing with perimenopause, menopause, and other female health issues that can challenge us. So I'm delighted to have Susanna here today. We're going to be digging into all of that. If you don't mind, I'm not going to read out your full bio, but I can share it. She is highly qualified, having trained initially at Pembroke College in Cambridge, and graduated in 2005, and since then you've worked through hospitals and been a GP and practices, and in the last few years have really focused and specialized in women's health, and I'm loving seeing this. Like, there's so many qualifications here around gynecology and sexual and reproductive health care that is about you really getting clued in, because there's not enough doctors that know what they're doing. And I think in this field, because it's not really been prevalent enough in the medical studies that you do. And one thing that really sets Susanna apart, as well as all of that, is your work in. You're a specialist in breast medicine at Cambridge Breast Unit, and so you support women after a breast cancer diagnosis, and that intersection of menopause and breast cancer is so important. It's probably one of the most feared and misunderstood areas, and I know it's always the thing that, on top of all the challenges you might face, can cause a lot of stress for women. So being able to understand a bit of that will be fantastic. And even better than that, so Susanna has a specialist online clinic to provide experienced support for women who are facing challenges with menopause, and that's called Cambridge Women's Health. And you have a supplement, Mellow8, to support us in that menopause transition. And I think having a supplement that's come from a medical practitioner like yourself, not something we're being sold on TikTok, gives me a lot more confidence and faith, because I'm one of those people that if it says menopause on it now, I'm like, I'm going to discount it. But apart from Mellow8, I'm all in. So welcome, Susanna.
Thanks for that lovely introduction.
Now, I know from chatting to you before that you've always wanted to be a doctor. So I would love hearing how you transitioned then into women's health and have become such a specialist in this area.
So I think I always wanted to be a doctor. I think I really enjoyed science things at school. And when I was young, my dad was quite unwell. I was in hospital quite a lot. And I think it sort of made me think, this is the sort of work I wanted to do. And as lots of kind of medical students, and when you first start working, it's often difficult to know what area you want to go into. But I think as a female doctor, often you do kind of attract female patients because they often feel it's a bit easier to talk to a female doctor about things. I worked in the hospital for quite a while, but I think I realised that hospital medicine was maybe not really for me. although I am watching ER at the moment, just sort of reliving those experiences, sort of binge watching that at the moment. But yeah, I realised sort of hospital medicine was not really where I wanted to be. So it sort of lended itself well to sort of moving into general practice. So I trained as a GP and I qualified as a GP in 2010. And yeah, during that time, I just used to see lots and lots of women. And as what happens in lots of GP practices, a lot of the patients will talk to each other and they'll sort of say, oh, you know, if you've got a women's health problem, this doctor's a really good person to go and see. And I found myself just seeing more and more women. And I realized that was definitely my sort of main interest and sort of key area that I wanted to work in. And so when I was a GP, I started doing quite a lot of extra training in my own time to kind of build up my qualifications and sort of skills in that area. So like you said earlier, I did lots of training in sort of sexual health initially. And then I did a community gynecology qualification to allow me to work sort of more specialist than as the general practitioner is generally. And during that time, I realized actually menopause was a really key area that I found it really fascinating, but I also found it quite saddening that the services that we were sort of providing at that time were not very good. And I reflected on the training that I might have had as a medical student, and very, very little actually on menopause at that time. I felt my understanding of hormone therapy was not great based on the training that I'd had up to that point, which is, it's really quite sad considering it's something that all women will go through. So I really decided that I wanted to focus more on that. So I did extra training with the British Menopause Society, and I qualified as a specialist with them, gaining sort of their registration status in 2020. And then I think I realised that I couldn't really carry on as a general practitioner anymore. I'd become too focused on women's health, and occasionally if a man came into my surgery, I'd be a bit like, oh no, this is not what I do. So I decided that actually I wanted to sort of change my direction a little bit and focus more on women's health. So I was quite lucky that things happened as they did. A position came up in the breast unit in Cambridge where I live, doing sort of breast assessment, but also trying to look at post-breast cancer support, and particularly focusing on menopause. And it really sort of fitted with what I'd been doing. So I started working there in 2019, and I've worked there since. And I've actually developed a menopause service within the department specifically for women who've had breast cancer. Wow. But I do some community gynecology as well. So I do a sort of a mixture of things, but it's all now sort of women's health based.
Brilliant. Oh my goodness, so valuable. And I know there's lots of people will watch and listen to this that are going to get lots of great information and just be delighted to see you specialising in these areas. And so, you said you spotted quite quickly that menopause was an area, and presumably that was maybe before we all became aware of perimenopause or whatever. So what were you seeing then, and what's the shift you're seeing now?
Yeah. So like I was saying, I guess, I would see a lot of women. So they would come to me, and when you're a GP, you can see when people have consulted other colleagues and what's been said. And I would often sort of look and think, these women have been having these symptoms, often things like mood changes with their periods. And it was all around the time that, we'd expect menopause to happen, but things were not being picked up. It was like people just weren't joining the dots. All these things were related to hormonal change. And I think that's what made me think, actually, I want to focus more on this, because these women are being sort of passed around, not really getting to the bottom of the problem. And I guess then, because I was picking this up, more and more women would then choose to come and talk to me, because they, like I said, they would hear from their friends or relatives that someone else who's going through menopause has got help with this doctor. And then I guess it sort of follows on from that. Within my practice, I then became kind of the doctor that my colleagues would refer people to me if there was issues around menopause. But so this was probably around 2015, which aligns with when the NICE guidelines, NICE guidelines were published, which was quite a big turning point in menopause care. So the preceding 10, 15 years had been really overshadowed by certain publications that were published around the turn of the millennium, really, sort of 2002 and 2003, which really worried a lot of women and doctors about the concerns around HRT and particularly breast cancer. And it pretty much led to a generation of women not being supported properly and being made to fear HRT. And then 2015, with the publication of the NICE guidelines, was a turning point. And it was that point where I became more interested in the newer types of HRT that were available. I mean, I remember prescribing micronized progesterone back then, and no one else had really even heard of it. It was actually quite difficult to be able to prescribe it because it wasn't on most formularies. When it came to HRT, it was very much, here are some tablets, whatever was first alphabetically in the list of the book that we often have with the different drugs that are listed. It was kind of that was quite early, and I think I was quite unique, particularly in my area. Obviously, there were pockets of people doing similar things throughout the country, but I do think that it was quite early in things when I started working in this area. Yeah. But I guess over the last few years, it's really become more spoken about, which has its positives and negatives. I think you sort of touched earlier on, you see the word menopause now and it's almost like, oh my goodness, not another thing, which is a shame, because actually I think it's really great that we're able to talk about it more and that women feel able to talk about it more. But I think that always opens up the potential for it to be then abused.
It's the marketing, the constant marketing
of things, and it's difficult. But on the plus side, if women are talking about it, that's always a good thing, because too long women's health issues have often been ignored or not given appropriate priority and things.
I'm definitely grateful for that, because probably like a lot of women, my early symptoms, and I look back and I think I had children. I had my second child at 39, and I think maybe even before, after my first daughter, my periods never settled. They were horrendous for the whole run, and low energy, low mood. And when I look at it now, I realize there was signs probably that I was becoming perimenopausal, but it was confused because of pregnancies. And then I was having symptoms that weren't really talked about. So, the memory loss, and low moods, and I wasn't having hot flushes. I was also 10 years younger than I thought I was gonna be, and it was thank goodness for people talking about it, particularly Davina McCall. She opened my eyes to what was going on. And I was saying to you that I realized a lot of my clients had come to me, and now I see, those early days with clients, a lot of them probably were perimenopausal, but they didn't know it. I didn't know it. And so they were dealing with stress, anxiety, low confidence, forgetting things, struggling to make decisions. And so it could show up at work first, and we dismiss it as a stress, or I'm too young. I still speak to women every day. Oh no, I'm too young. I'm 40. It's like, I hate to burst your bubble.
Sadly.
But you're probably not. No. So what do we need to know and look out for? What are the facts that we need?
So, I mean, I think perimenopause is definitely a term that I think is really important that people know about. I'm not sure that we were ever taught about that at medical school. I don't remember that term from medical school. But I think it's a really, really important term. And I think it's a time when women probably struggle the most. And usually it's mainly because they're getting a lot of hormonal fluctuation, and it's often that fluctuating, sometimes very high levels of hormone that can bring on a lot of symptoms. And traditionally, the diagnosis of perimenopause now is supposed to be a change in periods. So a change in cycle length that varies by more than 7 days is like the classical definition. Although I think now we're sort of trying to look at other ways of defining it, because actually I think we recognise that maybe some people don't quite have that. They may notice a little bit of change with their cycles, but some women can find their cycles can still be fairly regular. And I guess unless you're really tracking your cycles, which I know a lot of women do now, it can be quite hard to see that change anyway. But that is probably one of the things I would say, you know, look out for, is your cycle pattern changing. And yeah, like maybe using a tracker of some kind to sort of to monitor that. But other things,
we'll go back to what you were going to say.
yeah,
Interject there. But when, like me, I went on the marina coil because my periods were
yeah,
so
yeah,
bad, and
yeah.
so you don't have a
But yeah, and so this is one of the reasons why I think that definition is actually very difficult, because a lot of women will be using some form of contraception that is likely to change their cycle pattern. So the Mirena is a good example. So for a lot of women, that will stop your periods altogether, or it might make them a little bit erratic. The combined pill, if that's used, depending on how women take it, some women might take it what we call extended use, where they don't have any break and they don't have any periods with it. But it's actually that actually inhibits your ovulation pattern anyway, so that's going to artificially change what's happening. And then the progestogen only pill can make bleeding patterns very variable as well. So it's probably not the most helpful tool. But actually, if you're not on any hormones, you're not using anything, it is one of the things that you can look at. But yeah, there are lots of other symptoms that women experience. So hot flushes are obviously one that, I mean, traditionally, that is kind of what people associate with menopause. And it's true, probably about between 70 and 80% of women will experience some degree of flushing either during the day or during the night. And it can vary from just feeling a bit hot to that kind of real classic rising flush and then bright red and then sweating, and it, you know, there can be anything in between. So that is one symptom to look for, but you don't, like you said, you didn't experience those, so not everybody will get those. So then there are other things that are often maybe felt to be more psychological in nature. So mood changes are very common in men in perimenopause particularly, and this can be people who've had mood problems before and they may become more significant, or it may be people who've never experienced mood issues before and start to notice that. They might notice being more anxious, being more irritable. I'm seeing a lot of women now as well who are sort of starting to demonstrate symptoms of kind of ADHD, and we're seeing that a lot more. What the likely reason for that is that when they were premenopausal and their hormones were following a nice regular pattern, they were able to manage their symptoms. But as soon as this dysregulation of hormones kicks in, their coping mechanisms for managing those symptoms are no longer effective, and so these symptoms then become more noticeable. So I've definitely met a lot of women who've noticed those things starting to be more apparent. And then there are other physical things as well, so particularly headache issues and migraine type problems. I often ask women about whether they suffered with those when they were going through puberty, because puberty is quite similar to perimenopause, almost like the reverse. And so often people that struggled with headache and migraine problems then might notice them becoming a problem again around this time. And then I guess other physical things, sort of joint pain, aching, general fatigue, are other sort of common symptoms that women might experience as well. But there's obviously a huge list of things that
because there's like itchy skin, or I could have ripped my arm
itching,
red.
dry skin, noticing more dryness in the eyes is common too, because the change in estrogen is not just related to reproduction. You've got estrogen receptors throughout your whole body. So when you get changes in that hormone, it has effects on lots of different parts of your body, and you've got it in your brain as well. So it has effects on sort of cognitive function and brain function too. So it's a whole body issue. It's not just a reproductive issue.
I know, I often joke I've got every symptom except for hot flushes. But One of the ones that often, because I would do a lot of talks about managing your career, going through menopause, and as a leader. I also do a talk just for men about menopause in the workplace.
Yeah.
Possibly my favorite talk. Uh, they're amazingly engaged and very enthusiastic about it.
That's good.
Um, but one of the things that I noticed, and now my brain's going, Sinead, what were you going to say? Oh, it's gone. There was, you mentioned something there. Oh, I know what it was. A symptom that when I mention it in the talk, I see a symptom, but a lot of women go, oh my goodness, and it's a real penny drop moment, is suddenly becoming anxious driving at night.
Yeah. A lot of women talk to me about driving anxiety, and nighttime I think is a particularly common one because it's not great driving at night. I don't think anybody particularly likes driving at night, but yeah, becoming very anxious about that. And I've met a lot of women who get very anxious about driving anywhere they don't know. So if they feel happy enough driving to and from work, journeys that they do regularly, but suddenly if they're faced with having to drive, 100 miles somewhere different, they suddenly become, far more anxious about it than they would have done previously. That is actually, I've definitely had a lot of women who mention that.
Yeah, and it is like in the workplace, I would say, suddenly having anxiety or second guessing yourself about things that you would have done with ease before.
Yeah.
And then that leading to a real loss in confidence and doubting yourself and second guessing, like, am I going to space out in this meeting or, end up covered in sweat? All these things, and that just increases the stress and anxiety.
Yeah, definitely.
And I want to talk in a minute about how we can prepare for going to your GP and what to say and whatever. But that element of stress in it, because this happens to the majority of women, although I am aware that perimenopause can hit at any time post-puberty in very unusual cases. But it is the case, and I think we all need to know that in the workplace, because I think people look at, we're disbelieved at 40 plus. Imagine being 20 and going
they
through
estimate now that potentially 4% of women will go through menopause under the age of 40. Bearing in mind the average age of menopause is 51, and that's menopause itself. So perimenopausal changes could potentially start happening 10 years before that. I've met very young women experiencing menopause, usually as a consequence of either, a treatment that they might have had, often cancer treatment, teenagers that have had treatment for cancer. But sometimes it happens and we don't know why, genetic reason. So women under 40 that are experiencing menopausal symptoms, it's a really important group that we try and recognise and assess them properly, because the longer term health implications of that are obviously quite significant. Using that hormone a lot earlier than you should.
And for those of us that go through it at more of the average age, it's likely happening at a very crunchy point of life anyway.
Definitely.
You may be at the height of your career. If you've got children, they're getting to a point, your parents are aging, life stress, there's plenty of that. And so we can dismiss a lot of it as stress. And so what do you see in terms of the impact of stress and recognizing what's going on?
I think often people do put a lot of things down to stress, don't they? I think it's quite an easy thing to blame because we are all leading very, very stressful lives. I remember watching something recently about just the sheer amount of information that our brains receive now compared to even just 20 years ago is huge. And all of that is really, really stressful. So it's likely that stress has a big part to play in a lot of the symptoms we experience. And it definitely can make menopausal symptoms worse. But I think it's really important that it is recognized that menopause, hormonal changes could well be taking place here, and not just putting something down to stress. But I think it's also important to recognize that actually we can manage someone's menopause, but actually if they're still faced with significant stress in their life, it's likely that whatever we do is not going to totally resolve problems. And so I think this is one of the challenges sometimes with hormone replacement therapy, and someone's symptoms don't always get better as we might expect. But actually, when you sort of go into details about what's happening in their life, they're hugely stressed with lots of different elements of their life. It's important that they tackle those as well, because obviously giving somebody hormones is going to be great to help stabilize their hormones, and it might help them deal with some of these situations more effectively. But ultimately, that does need tackling as well. I've had quite a few patients recently where they've been really struggling at work with various issues, and we've been really, working hard on getting their hormone therapy right. And then they make the decision to either change their job or make a decision with that, and that has a hugely beneficial effect. So we've got to remember it's not just about all the hormones, but about the whole sort of life picture.
And that's where we're like a team here, because that's what I deal with. And we don't want, yes, I think at times it's really important for women to make those changes in the workplace, but it's making the right changes.
Yeah, definitely. We don't want people having to leave a job because their menopause is making it difficult. And it's difficult, isn't it, sometimes to get that balance right?
Yeah.
But yeah, I think, exactly on the sort of reverse of that, I've sadly met women who have left jobs because their menopause was affecting them so badly, and they still don't get better. And then we manage their menopause, and then they suddenly like, oh, I probably could have stayed in that job. And that's a real shame as well.
I know, like one of the things that I really help women with is that whole management of learning the strategies that really work to navigate stress and to minimize that. And that's been the thing that's really worked for me, because my symptoms were quite severe in terms of rage, suicidal thoughts, low moods, and but actually it's been the balance of HRT, yes, solves a certain amount, and then working on that mindset piece to really help me balance. And that's what I love helping women with. So I'll be like, get to the doctor first of all, that's non-negotiable. I think, and then let's work on this together. And both things make
I think it's good to sort of tackle the hormone element early on, because obviously try to do other things, but the hormones are all over the place. There's a good chance that actually they're never going to be able to cope with that. They're not going to be able to manage those symptoms effectively. And I've definitely had a lot of women who have said to me, once they've got settled on a really good HRT regime, the things that were happening in their life are still there, but they feel able to manage it so much better. So I think tackling the hormone side is really, really important. But it is, it's about being realistic and recognizing that there are other factors at play as well, and supporting, which is why it's really good having kind of input in workplace settings, because I think that's a really good place to promote sort of good menopause support, really.
Yeah, and it is where it tends to show up first. Where we see the changes, and so how do we prepare to go to the doctors, and then what do we say when we get there?
It's hard, isn't it? Because when I was working as a GP, I quite liked it when people came in knowing what they wanted. Obviously, we'd discuss it and I'd make sure it was the right thing for them. But it's nice to know what somebody's actually wanting to get out of that consultation. It makes the time you have with your doctor so much more efficient. And sadly, one of the big sort of limitations to care, particularly in NHS at the moment, is the limitations on time. So a lot of GPs do not have very much time allocated for every patient that they see. As much as people maybe don't recognise this, but GPs have to see significant number of patients every single day. And so doing something to make it as efficient as possible, I think, is probably a really good way of trying to approach it. One of the things I would say, though, is maybe trying to find out beforehand who is the best person to go and see. So lots of practices now are kind of joined together, or they are sort of a bit bigger, and they'll often have multiple doctors, and doctors will now probably have areas that they kind of have more of an interest in. And I guess it was the same for me back in 2015. You know, I was showing this interest of menopause support, and so the women who wanted help generally sort of then knew to come and see me. So that would be one of the things I would say first off, is to sort of find out from your practice which doctor is more able to support me with sort of a menopause discussion. And actually, it might not even be the doctor, it might be a nurse. So lots of nurses now are doing a lot of extra training in menopause care. And I think actually they're really well placed to do that, because they do deal with a lot of women's health throughout their sort of role as well. So finding out who would be the best person to go to. And then before you go, I would actually have a little think about the symptoms that you're experiencing and see if you can actually document them in some way. We were saying before about period tracking and things like that. There are online tools where you can track symptoms now as well. You can kind of keep a record of symptoms that you're experiencing. And if you can do that and show that to your GP, sometimes being able to look at that, it can shorten the length of time that it takes to kind of describe all the different issues that you're experiencing. So I think that can be really, really helpful too. And then I would say go in with having a thought as to kind of how you want to approach it. You know, do you think that you would like to approach it with non-medical things? Do you want to consider hormone therapy, or are you open to sort of discussing all of those things? Because a lot of what we do now in medicine, it is patient-led, and we are wanting to support patients with what they want to do. And that will help guide that sort of discussion as well. But I guess the other thing I would say is don't, you know, it's so difficult, isn't it, online at the moment, and there's so much information out there. You've got to be a bit cautious of having a preconceived idea as to what should be done, because that may not always be correct depending on what your source of information is as well. So I think sadly now lots of information is coming online which is incorrect, but people are kind of taking that as gospel, and that's, you know, that's what should happen. And then they're going to their doctor, and then when their doctor is sort of questioning it, they can sometimes become a bit defensive and angry about it. And it's really difficult, because if you've heard somebody online say this is what you should be doing, and then your doctor's saying you shouldn't, it can be really, really difficult to know, well, who's telling me the right thing here. So I think it's about getting the information from, you know, reputable sources as well. We sort of said about TikTok, didn't we? It's like, yeah, I'm not sure that's the best place to be getting medical advice unless it is an actual doctor that's kind of.
Yeah. There are some good doctors on there, but
yeah,
there's a lot of rubbish
I
too.
was starting to think maybe I should start doing some TikTok videos, but I hate making videos. So yeah, I'm not quite sure I'm there yet. But I mean, I've got a few colleagues that do some educational content on TikTok. I think the problem is it's hard to know who to trust on those sort of settings. And I don't know if there's an easy answer to that, unfortunately, with a lot of misinformation now being kind of shared. But going to reputable sources like the British Menopause Society, for example, provide lots of really good information about menopause care. They have a patient arm of their charity, which is called Women's Health Concern. And so you can access more patient-friendly information on there. There are other sources of information too, but you know, I'd be going to those as your first port of call, rather than some influencer who's maybe not got any medical background.
Yeah. Can I ask, because one thing that women get very conflicting information on is the blood test. Like, you know, when you should be, because I know there's an age point where it should just be trusted on symptoms, and the blood tests aren't going to tell you much. So what's the
answer?
Spill the tea on that, as the kids would say.
So yeah, I mean, it's quite topical this actually, because the British Menopause Society released a publication last month about this kind of issue, because there are more and more companies out there now offering these kind of hormone profile testing, a battery of different tests telling you, you know, we can individualize your treatment based on these tests. And I think more and more women are having these tests. I'm definitely seeing more women in my clinic sort of, and when they've booked in, I notice they then upload this kind of huge document of all these tests that they've had, and goodness knows how much they've paid for this kind of profiling. And the difficult thing right now is we just do not have the evidence to support using these test results as a way of managing someone's menopause. And the reason for it is, well, there's lots of different reasons, actually. One is our understanding of how hormones work on an individual basis is still very, very limited. And we know that hormones do affect women in lots of different ways. And just ask yourself, if you talk to your friends about how they feel when they get their period, it can be very different to how you feel. And so hormones influence people on a very individual basis. And the levels of hormone in blood change very significantly, quite a lot throughout the day. Our bodies respond to things constantly, and so doing a blood test is literally just a snapshot of hormones at that moment in time, and most of the time we can't interpret that information. It's not helpful, and so what we've really shown is that we should be monitoring women based on how they're feeling and what their response is to the treatments that we're using. Now, I know it can be really it feels very unscientific. And I feel that myself sometimes when I'm saying to someone, I can't do a blood test, it's not going to tell me what's going on. But sadly, at the moment, that is kind of how it is, because our understanding of the hormone levels is still not there.
I'm seeing the flip side, though, that women are not being believed and their doctors are insisting on a blood test. And
that's frustrating, because that's not what should be happening. And I can totally understand that as well. But that's not a reason for us to then start doing a battery of tests that are totally uninterpretable, because that's doing women a disservice as well. But I totally understand. I think sadly what sometimes might happen in maybe a GP setting, because of the time pressures, it's quite easy to say, well, let's do a blood test and then I'll see you with the results. And I can look back to when I was a GP, and with certain things I may well have done the same, because it's kind of, I can get something, this patient feels like they're having something done, and then I can take a bit of time and then think about what these results might show. But the problem is, we've shown that those results are so varied from one person to the next that actually the result is almost meaningless. Obviously, there are certain situations where it is important, and a good example is a woman who's experiencing menopause at a very young age. So in that group, yes, we do want to know, has that woman's period stopped because she's gone through menopause earlier than she should, or is it because of something else? Is there some other medical reason why this has happened? So in women under 40, blood testing is important, because we need to know what's going on. In women between 40 and 45, would be considered early for menopause. It can be useful in that group of women, probably more useful to make sure that we're not missing another medical problem. So thinking about checking for anemia, checking for thyroid problems, checking for other things to make sure we're not missing another medical reason why they're symptomatic. But once you're over 45, if you're experiencing symptoms that are suggestive of menopause, there is absolutely no benefit in doing a blood test, because it doesn't tell us the answer. If anything, it could come back normal, which often it does a lot of the time, and then that woman gets told it's not your menopause, which is wrong, because actually it was normal at that moment, but if they checked it a week later, it may have said something totally different. And it also doesn't guide how we would treat you, because actually there is no consensus as to what level we need hormones to be, because everybody is different. So what level of hormone you need is very different to what level of hormone I might need. So we can't tailor someone's HRT according to that, because the level in the blood, well, actually the only thing we measure is estradiol, but actually there are 4 different types of estrogen that exist, 3 of which are in most of our bodies. There's one form that is really only found in a fetus, but the other 3 forms are all found in our bodies to varying different degrees, depending on where we are in our life sort of pattern. So just measuring estradiol, for example, is not that helpful. We can't distinguish between natural hormone production and estradiol that we're giving you in HRT. So when we do a blood test, we don't know if it's the HRT or is it your natural hormone. So there's so many variables that just make it really, really unnecessary. I think, in the future, it would be great if we could use blood testing to help guide what we're doing. And maybe that is something that will happen. But the problem is women are having these tests and then
no, we need much more funding in women's health, don't we?
I went on a bit there.
And when if your GP isn't listening to you, your doctor isn't listening to you, and saying, "Oh, well, your blood test's not showing anything," or whatever it may be, what do you do?
Well, I think in that blood test situation, I think sadly, often it's better if you've not had them, because then they can't say that to you. But if you feel like your doctor is really not listening to you, then you are very within your rights to ask to speak to someone else, or to say to that doctor, well, is there someone who has more of a background of menopause that I could speak to? You can ask to be referred to a menopause specialist. I know there's not as many menopause specialists throughout the country as we need, but there are more and more now. And so usually in most areas, there is somewhere that you can be referred to. I think the problem there is there's often a lot of waiting around for those appointments, because the waiting list is often long. But maybe it's about that, just trying to find the right GP to speak to. And I think a lot of practices do have lots of different GPs. And I think lots of GPs surgeries now are trying to direct patients to the most appropriate person to support them. But the answer to that is, I think, speaking to somebody else if you feel like you're not getting the right answer.
Yeah. And obviously you're a specialist in the area of breast cancer. And so, that it's a very difficult time anyway. But then menopause coming into play and whatever. What some advice you can give to somebody experiencing that, and what options there are?
So if you're going through breast cancer right now and you're going through treatment, most breast units, well, they all really should have a support service in place for women, and that we usually follow women up for about 5 years after they've had their breast cancer diagnosis. And it's often during that time that a lot of women will struggle with menopausal related symptoms. So speaking to your breast care nurse is a really good sort of first port of call. I think more and more services now are kind of offering support for women post their diagnosis, although I don't think there's a menopause clinic in every department, sadly. I know that locally I'm probably one of the only ones, although throughout the country there are more and more colleagues like myself that are sort of setting up these services. But there are other sources of support. So Maggie's is a charity that we often direct people to, and they have centres throughout the UK, and that's a cancer support charity. A lot of them do kind of focus on menopause support. So actually, it doesn't just mean breast cancer. It actually can be any woman who have had any cancer. There's another charity called Menopause and Cancer, which is quite new, that over the last couple of years has been set up. And that's got lots of really good support information for people who've had, again, any type of cancer. They have a podcast, they've got lots of information online, and they're building their resources quite a lot now. So that would be another support service that I'd encourage women to go to. And then there are lots of ways in which we can support women post breast cancer. We can look at non-hormonal interventions. There are lots of things now that we can potentially do. There are some new medications coming through now, which we're actually currently, where I work, part of a trial looking at one of these new medications that's for treating hot flushes, which is going to be, I think, a bit of a game changer for a lot of people who've had breast cancer. Hopefully that will become available soon. And then eventually I do sometimes have the conversation about whether hormone therapy could be considered in some situations. Now, it's not something that we would do lightly. That does come down to having kind of quite detailed discussions on a very individual basis. But in some cases, if women are really, really struggling, that may be a discussion that we might have.
Yeah, I remember speaking with a consultant whose perspective was, if your life has been so dramatically impacted related, it's certainly worth the discussion. And
I do have some women who choose to take HRT after having had breast cancer, but it's a very individual decision.
There's a couple of things that I know, some of the more embarrassing symptoms, but can actually be made manageable. So like urinary and incontinence, severe, blood floods, we would call them informally, but that really heavy breakthrough bleeding and whatever. What would you encourage women to do if they're experiencing those kinds of symptoms that are really holding them back?
Yeah. So I know it's always hard, but I would encourage you to go and speak to your doctor about it. We've seen lots of this already. I see this every day in the job that I do, and lots of GPs will have spoken to hundreds of women with these problems. So we're not fazed by people telling us about these things. So don't worry about that. And I would say particularly something like heavy periods. So I've met women who've struggled with heavy periods for a long time before they've come to speak to me about it. And like you say, flooding really impacting them at school or at work or wherever they are. And there are lots of things we can do to improve that. And it's not normal, it's not normal to flood like that. Now, I'm not saying it means there's anything sinister going on, but it usually means there's something going on that means you're bleeding more than you should be. And not only does that just make things horrible for you, because it's really not nice to be dealing with that, but if you're bleeding really heavily like that, you can become anemic, and that could obviously have other health implications too, and can make you feel really quite unwell. So you don't have to put up with that, and I would say go to speak to your doctor about it. The other thing is genitourinary syndrome of menopause, which is a bit of a mouthful. But yeah, that's really common too. So this is essentially either vaginal or vulval symptoms or urinary tract-like symptoms that are often related to that loss of estrogen, or the changing level of estrogen. And actually, interestingly, it can start happening quite early. It doesn't have to be kind of years after menopause. So if you're experiencing those symptoms as well, again, talk to your doctor about it, because there are lots of vaginal treatments that are really simple, easy to use, really, really safe to use. They're not like systemic HRT if you're worried about hormones. They're very safe and very, very effective. I would say we should be giving those to lots of women now.
Because I was seeing some information out there there's a few very good doctors on Instagram that I follow, and saying that if more women were given vaginal estrogen at this time, probably a lot of our mums and grannies have been plagued with UTIs and constant problems, and it would have stopped all of that.
Yeah, definitely. Getting recurrent urinary tract infections is a classic feature of genitourinary syndrome of menopause, and it can be managed so easily with vaginal estrogens. And I've met women who've gone through various investigations, camera investigations into their bladder, and not one person has thought about giving them some vaginal estrogen, and the difference it can make is huge. And urine tract infections, particularly as women get older, can be really serious. People can end up in hospital. They can end up with sepsis as a consequence of these infections. So it's not something to belittle either. I know we often think about cystitis as, but actually,
it's so debilitating.
Really debilitating. And it can be often, that cycle can often be broken with using treatment.
We could talk forever, but you've actually reminded me. When I do talks, I talk about the symptoms. I'm not diagnosing anything, and I talk about the career and leadership impacts of that. But one session I did, I remember a woman came back to it when I was doing a follow-up in the business, and she told me, you mentioned joint pain, and she had been having knee pain for years, and she said she had been to every specialist and consultant under the sun, and after my talk she went and said, could this be hormonal? can I try HRT? And she said it was gone in a couple of days.
Yeah. Yeah, I've definitely met women where that's been the case as well, because
Yeah.
it is a common symptom, and we know that estrogen affects the integrity of the sort of the soft tissues that support your joints. We see it in pregnancy, the hormone changes that affect them. There's massive hormone change in pregnancy, but yeah, in perimenopause and menopause, it is a really common symptom. And often when the joints are investigated with scans or whatever, you can't see anything. They look normal. And so I've definitely had a lot of women who find that improves dramatically.
Well, I thought I needed a hip replacement, and it turned out I just needed HRT, and that was a big relief. Any last tips or anything that you think will be useful things to know in this situation before we wrap up? We were going to talk endometriosis and PCOS, but we've just run out of time. I will maybe get you back another day.
I think we've probably touched on the big things that I think are really important. So one is age not being a defining factor. I think when I do my talks about menopause, it's one of the first things I say. I show a picture of 3 women of various different ages and ask them who of these could be affected. And the answer is all of them. I've met women who are very young. I've met women who are older as well, who are still suffering with symptoms. Although that's not the norm, it can happen as well. So I think that what is a key thing is please don't feel that you're too young, particularly too young, to sort of be going through hormonal changes. The other thing, I suppose, is about being realistic with kind of what certain things are going to achieve, and hormone therapy, I think, being a good example for that. It can be amazing. It can make huge differences to people, but we've got to also recognize it's never going to be exactly the same as what your natural hormones were like. So sometimes it might be that we're never going to totally be able to resolve everything with hormone therapy, and that's where other interventions and things are really important. So managing someone's menopause really is quite a holistic thing. It's not just about focusing on medicine and HRT. It's about focusing on everything. But don't be worried to go and talk to someone about problems. And I think this really sort of covers not just menopause, but I know we didn't get on to talking about endometriosis, but any issue that you think is not right, you should go and speak to your doctor about it. And most of the time we'll have heard it before, and it's not, we've probably got a solution to help support you. And don't feel like you have to battle on without any support, but maybe looking for a doctor within your practice who has an interest in women's health is probably a good way to go.
Yeah, brilliant. Yeah, I always say, start with your GP. Look at your stress. What can you do to manage your stress? Because that can really help. Because quite often the things of exercise, which is going to help, but if your joints are sore, you're exhausted, it doesn't feel available to you. So those 2 things are going to get you in a good place. And then exercise, nutrition, and sleep can kind of...
Yeah, that's one thing we've not really touched on, sleep. But actually that is a really big part of menopausal issues as well. And I think our understanding of sleep has always been quite limited, but actually now I think we're recognizing more and more sort of what's going on when someone isn't sleeping well. And there's a lot of good evidence to show that poor sleep will impact menopausal symptoms, particularly sort of brain fog issues, but also other kind of psychological issues, and also flushing symptoms too. And actually the British Menopause Society have just published some more advice on how we should be approaching issues with sleep. So that is another big part of it that we should be addressing for women. And if we can get sleep better, often has a knock-on beneficial effect with lots of other things.
Yeah, absolutely. Oh, thank you. I literally could talk to you for hours. Sorry, I just nearly ended the stream before I finished talking there. Thank you so much, Susanna. I'll share the link of your online clinic, which is a place you can go and get support if you're struggling with your own GP and to be listened to. And of course, the Meno8 supplement, which is full of the key things that are going to really help you.
Yeah, I sort of developed it really to try and simplify things. I was saying to women in clinic, you know, these are the things I would say are worth taking, because there's lots and lots of things available and it's just really confusing. So it was really just to try and simplify things. But I do go into it sort of saying this is not a replacement for HRT, it's not a
No.
replacement for healthy lifestyle. It's just a bit of extra support, but containing the things that I think help, as opposed to lots of other random things that probably don't.
Yeah, brilliant. Thank you so much.
That's okay.